thank you so much for that introduction. And thanks for everyone who's joining us from literally, looks like all over the world. So I'm going to talk about COVID-19 vaccines and booster doses. And whenever I talk about COVID-19 or SARS-CoV-2, the virus that causes COVID-19, I have to give this disclaimer. Information about this disease and the virus are literally continuing to evolve daily, and our recommendations are changing frequently. So what you hear today may be outdated soon, or it may be outdated by the end of the week, or certainly by the end of the year. So you need trusted sources of up-to-date information. So in New Jersey, that consists of the New Jersey Department of Health. Wherever else you are, your departments of health are good places to go for accurate, updated information. The Centers for Disease Control and Prevention, and of course, the World Health Organization. And then for information about children, the American Academy of Pediatrics is a great source, and they have a website that is specifically designed for parents. And that is this healthychildren.org. And it will really give answers to just about anything you want to know about with regard to children in COVID and children in vaccines, et cetera. And there's also a page in Spanish to increase the chances that people can access this information. So my objectives are to help you so that by the end of this webinar, you can counsel a person regarding the need for a booster dose, address the side effects of the vaccines, and counsel parents about vaccinating their children. So let's start with just a little review about COVID-19. So this is the name that was given to this disease by the World Health Organization. It stands for coronavirus infection and disease. And the 19 is because it was first recognized in 2019. Now, the virus that causes this disease is called SARS-CoV-2. It's SARS-CoV-2 because the first SARS virus, and SARS stands for severe acute respiratory syndrome, that happened in 2003. And interestingly enough, it was gone by the next year, gone completely from the world by 2004. That hasn't happened with SARS-CoV-2. This virus seems to have figured out how to make things miserable globally. And this is truly a pandemic, hopefully the pandemic of our lifetime. We now know that this is spread primarily by droplets. And what are droplets? Droplets are those little spit particles that you make when you talk or when you sing or when you sneeze. And if we take a look at this person sitting in the chair, if he's infected, he may or may not know it, but whenever he talks or even breathes, he's putting virus out into the air in these little droplets. And the person standing close to him is getting exposed to those viruses. Now, it's very easy to see how if this person sitting in the chair simply had a mask on, that mask would catch the viruses. And if this person had a mask, the air that he breathed in would be filtered through the mask. So for this person in the chair, the virus would be on the inside of the mask. And for the person standing close by, the virus would be trapped on the outside of the mask. So masks alone make a big difference. And remember that most droplets will fall to the ground within 3 to 6 feet. So I said this disease is primarily spread by droplets. Occasionally, there is true airborne spread. So let's take a look at this person making droplets in the best way possible, and that's by sneezing. And I think you can see that there are tons and tons of droplets here. And most of them are indeed falling to the ground within that 3 to 6 feet. But occasionally, in some people, some of these will become truly airborne and will cause infection in people on the other side of the room, or generally it's the other side of a large room. And then in that case, you have a super spreader event and you have true airborne infection. But most of the time, the transmission is by these larger droplets that are falling to the ground. So if that's the way COVID spread, then it makes sense that there are simple things we can do to prevent the spread. Wear a mask that covers your nose and your mouth. If you're infected and don't know it, it will catch the virus, so they won't go out in the air. If you're not infected and you're breathing in and the air has virus in it, that virus will be trapped on the outside of your mask. Stay about 3 feet apart, at least 3 feet apart, whenever possible. And that's about 2 arm lengths. Stay that far away from others so that you won't be exposed to those droplets. Avoid crowds and sick people. Why? Because in a crowd and with sick people, it's very hard to keep that 6-foot distance. Wash your hands often. Now, this is something every infectious disease doctor will tell you time and time again. It turns out for COVID-19, it's not quite as important because COVID virus is not really transmitted on fomites, on surfaces, but it's very important because a whole variety of other things do get transmitted on surfaces, doorknob handles, your phone, anything that you happen to touch in your environment. So things like influenza virus, which is now beginning to circulate, and a variety of bacteria are spread on surfaces. So washing your hands protects you from those other viruses and the bacteria, which can complicate a COVID infection. And then as soon as you're eligible and as soon as you're able, get vaccinated. And as soon as you're eligible for a booster, get that booster to really boost that protection. So this is, as I mentioned, a global pandemic. So this is from the World Health Organization, and the darker the area, the more disease that's been present in those countries. You can see there are only 2 countries that claim no disease, North Korea and Turkmenistan. And most people think that's unlikely. It's just that they're not reporting cases. So this is truly global pandemic. And if we look at the numbers and see, what's happened so far, we see that in the last 24 hours, there were 82,000 new cases. So far, there have been over 252 million cumulative cases, and unfortunately, over 5 million cumulative deaths. Well, let's see what's happening here in the United States. And for me, because I'm talking from New Jersey, here's what's happening in New Jersey. So for the United States, the information is that we've had a variety of different peaks here of disease. And right now, what you see is not comforting. We were hoping this number would continue to drop, but you see that it's leveled and in fact is starting to go back up. And this is another surge that we were hoping would not happen as we move into the holidays. In New Jersey, we pretty much mirror the rest of the country. So we had our initial surge very early. And now, whereas we were having kind of a falling incidence of disease or leveling, we are also starting to have an increased amount of disease here in New Jersey. So what about this illness itself? So first of all, remember that disease varies from no symptoms at all to a mild cold to pneumonia, multi-organ involvement, and death. To date, over 759,000 deaths in the United States and over 25,000 here in New Jersey. Disease in children is usually mild, or the children have no symptoms at all, but that's not always the case. And in fact, in the last 2 years, there have been 911 deaths in children in the United States. And this is far more deaths than we would see in the usual influenza season. In New Jersey, we've had 8 deaths. We also have this very unusual disease called the multisystem inflammatory syndrome. And this occurs, it appears to be an immune problem. And in fact, what happens is about 2 weeks to a month after a child has been infected, their immune system just kind of goes berserk. And instead of fighting off the virus, it actually causes disease in the children. They present with high fevers. They can be in shock, and they usually require hospitalization and intensive care to get them through that acute multisystem inflammatory syndrome. So everything's inflamed: the lungs, the heart, the gut, And all of these symptoms make it extremely hard for them. The good news is that most children will survive this, but it's an intensive care stay, and we don't know if there will be any really long-term consequences. To date, we don't think so, but we don't know. How common is this disease? Within New Jersey alone, we've had 141 cases and fortunately no deaths. Reported to the Centers for Disease Control as of the beginning of November, there were over 5,500 cases and 48 deaths. So this is a problem that clearly does occur. And like the rest of COVID-19, it is not equitable. We know that the majority of deaths in this country have come in people of color, Hispanics, Latinx, and African Americans, and our indigenous population are Native Americans. The same is true of multisystem inflammatory disease. Hispanics and Blacks are much, much more represented than whites or Asians. We don't really understand why, but this disease has really taken quite a toll on people, and it's not been equitable. If we look at what's happened to children that aren't infected or haven't been necessarily infected with the virus, they are still very much affected by this disease. So over 140,000 children have lost a parent, grandparent, or a caregiver due to COVID-19. And again, not equitable. 1 in 168 American Indian and Alaskan Native children, 1 in every 310 Blacks, 412 Hispanics, 612 Asians, and 753 whites. This is a lot of horrors for children. So if you think about losing a parent, a grandparent, and a caregiver, that's an adverse childhood event that is going to affect the health of these children literally for the rest of their lives. In addition to that, we know that most children lost a whole year of school last year, and many are still missing out on school this year because of quarantines and isolation. And all of us have missed a multitude of celebrations and events, whether it's graduations or, a wedding or even funerals. We've missed a lot of ability to interact with each other and to celebrate our joys and to comfort each other during our sorrows. In addition to that, we have this problem with what's called post-COVID conditions. And these are symptoms that are still present at least a month after your infection. It's been called long COVID, long haul COVID, or post-acute COVID. And here are the symptoms. The symptoms are difficulty breathing, becoming tired or fatigued, and all of these symptoms get worse after activity. Cough is prominent, and pain in the chest, the stomach, the joints, the muscles, the head, and the abdomen. Palpitations occur, diarrhea, pins and needles feeling of your extremities, sleep problems, fever, dizziness on standing, a whole variety of rashes, menstrual changes, smell and taste changes, and mood changes. And probably the most concerning is this brain fog. So this feeling that you can no longer concentrate. You can't read a paragraph, or you read the paragraph, but you have no idea what you just read. Many children have lost their ability to do simple math. So this brain fog where you can't seem to learn new stuff and you have trouble with short-term memory is really a major problem, particularly for children who are trying to go to school, and school is the job of childhood. And this brain fog clearly will interfere with that. Now, how common is post-COVID? Well, it depends on which series you look at. In one series of adults, it was up to 80%, but most people would say it's probably more like 50%. And in children, it appears less common, or maybe they just complain less, but it's more like 5 to 15 or 20%. But no matter how many it is, it's way too many, and it really is interfering with people getting back to their usual vigorous lifestyle. So the good news is we have vaccines that are safe, they're effective, and they're free for everyone. You can get a vaccine if you're insured, if you're uninsured, if you're documented, if you're undocumented. If you're in New Jersey, you can go to a vaccine center and get a vaccine, provided you're 5 years of age and above. Now, what's happened with these vaccines? Well, the licensed vaccines in the US are the messenger RNA vaccines, Pfizer and Moderna, and one of the adenovirus vector vaccines, the J&J or Janssen vaccine. In the rest of the world, the other adenovirus vector vaccine is also widely licensed. And right now I'm blocking on its name, but it'll come to me when I stop trying to think of it. So the Pfizer vaccine was authorized for use here first in December, the middle of December in 2020, and it was authorized for ages 16 and older. That emergency use authorization was extended down to age 12 in May of 2021. And it was fully licensed for use in ages 16 and older, and it's licensed as Comirnaty, and it's licensed just as a 2-dose series. An emergency use authorization for a 3rd dose for immunocompromised people was issued in the middle of August, and then the booster dose was authorized at the end of September. And very recently, the age has been expanded down to 5 to 11 years, and that was just at the end of October. For Moderna, it's been in the US a little bit behind. So a week later, the initial emergency use authorization, and it's of course for ages 18 and older. Now, why the difference in ages? Because that's the way the pharmaceuticals tested their products, and that's the information they gave to the Food and Drug Administration. Moderna was also authorized for that 3rd dose in the middle of August, and for the booster dose at the end of October. The adenovirus vector, the J&J one, or the Janssen, was a little bit later to come onto the market in the US. At the end of February, it was authorized for use. And again, it's for adults 18 years of age and older. And a booster was authorized at the end of October, the late middle of October. Now let's talk about how these work. So the messenger RNA vaccines, messenger RNA is simply a code, and it codes for that spike protein. And you take that code and you put it into a little bit of fat, a lipid nanoparticle. Why do you do that? Because you need the lipid to allow the messenger RNA to get into the dendritic cells to process this antigen. So when they process the messenger RNA. So when it gets into those cells, the code is read and spike protein is produced. And because that's not a human protein, a brisk immune response follows. And that is both an antibody response and a cell-mediated immune response. The RNA vaccines are 2-dose series. And if you're immunocompromised, you need 3 doses. For Pfizer, it's 2 doses 3 weeks apart. For Moderna, it's 2 doses 4 weeks apart. Why the difference in timing? Because that's the way the companies studied it. And then the booster doses are for 6 months after you complete the 2nd dose for older adults and those at risks. And those criteria are really beginning to become expanded. And we hope soon that the booster doses will be available for people whose immunity is waning. The J&J vaccine, again, you have the code for the spike protein, but this time, instead of being put into fat, it's put into an altered human adenovirus. And this is adenovirus 26. And you put the code in there. The adenovirus is a replication incompetent virus, so it can't make you sick, but it does allow the code to get into the cells, releases the messenger, the RNA code, and the spike protein is produced. And again, you get the brisk antibody response. It was given as a single dose, and now it's clear that the immunity does wane after that single dose. So a booster dose after 2 months is recommended for everyone who's gotten the Janssen vaccine. So what are the side effects of these vaccines? Well, if we start with the messenger RNA vaccines, the most common side effects are those that you would expect with any immunization. So that's pain at the injection site, fatigue, fever, headache. And these are just common effects that you're going to see. The side effects are less common in people who are over 50 years of age, and they're more common after the 2nd dose. There are some serious side effects of the messenger RNAs, but they are rare. The first is anaphylaxis. Anaphylaxis is a severe allergic reaction. It occurs in somewhere between 5 and 10 per million people who get this dose, which is a little higher than we would expect after most vaccines. It's usually about 1 to 5 per million. So this is a little bit higher. And anaphylaxis occurs almost entirely in women and in people who have a history of having anaphylaxis to other medications or to other vaccines. The second serious side effect that was noted was myocarditis and pericarditis. And this was noted in about April. So remember, the vaccine was first started to be given in December, and about April, it was appreciated that there was more than the expected amount of carditis and a little bit of pericarditis, mainly in adolescents and young adult males who had gotten the second dose of the vaccine. Now, this myocarditis is very different from the myocarditis that you get from most viral infections. That is a severe disease. It ends up with hospitalization, heart rhythm problems, and prolonged. But the myocarditis that follows the vaccine is very short-lived. The patients do present with chest pain, and when you measure their cardiac enzymes, they're elevated, but this is very short-lived. It's almost always gone within 12 to 24 hours, and there do not appear to be prolonged side effects. So that these are absolutely serious side effects, but again, they're rare, and they're rare enough that after evaluation by all the safety committees, it was decided that the benefits of these vaccines outweigh these side effects. Now, what about the adenovirus vector vaccines? So in this case, again, most common complaint is just that pain at the injection site, fatigue, fever, headache, signs that your immune system is working. So those are kind of the expected effects, but then there are some more serious side effects. And again, with those common side effects, they're less common in older people, and they were less common with J&J because it was a single dose. The serious side effects, again, are very rare, but they do occur. So after the Janssen vaccine started to be used in the US, the end of February, 2 months later, it was noted that there were 6 reports of a problem that's called thrombocytopenia and thrombosis. So low platelet counts and clotting of the blood. And unfortunately, these thromboses were life-threatening in some instances. They were in the veins surrounding the brain, also some in the lungs, and some in the abdominal major veins in the abdomen. So because of that recognition, in the middle of April, the use of Janssen vaccine was stopped for 10 days while all of the safety people collected the data to really look at how often this occurred. And it was much more common in women. As a matter of fact, almost entirely in women. And it was younger women. So they looked at all the information and they weighed the risks and the benefits. And again, the opinion was that the benefits of these adenovirus vector vaccines outweigh this risk. So the Janssen vaccine continues to be used. The other thing that was noted in July was that there was a slightly higher number than expected of cases of Guillain-Barré syndrome. Guillain-Barré syndrome is a neurologic problem where there's ascending paralysis. So it begins with weakness in the feet and then goes up the body and can result in weakness of the diaphragm and need for some ventilation. It's almost always self-resolved over time, and recovery is generally complete. So again, all of these vaccines are going to have common side effects, and then there are going to be rare but serious side effects. However, the benefits are still exceeding any of these risks. Now, one thing that isn't affected by these vaccines is fertility. However, there has been so much misinformation put out there that I have to talk about fertility and say that there is absolutely no evidence of any effect of COVID-19 vaccines on either male or female fertility. So despite what you may have heard or read, there's no biologic reason to expect fertility problems. There's no clinical evidence of it. And in fact, there's no vaccine that affects fertility. The American College of Obstetrics and Gynecology has very strongly recommended this vaccine for all eligible people, for those who are pregnant now, are breastfeeding now, or who may consider future pregnancies. And the Centers for Disease Control and Prevention has also widely recommended this. And they've even sent out an alert to remind people that pregnancy puts a woman at higher risk for complications, so they definitely should be vaccinated. And what about variants? Well, whenever a virus replicates, there can be variations in the DNA or RNA in this case, and that results in a variant of the virus. These variants have been described as variants of interest, variants of concerns, and variants of high consequence. A variant of interest is one that might have an increase in illness or transmission. A variant of concern is one that clearly increases transmission and illness. And we've had many of those so far. Alpha, and they're named after Greek letters, alpha, beta, delta, and gamma. And there are mu and a variety of other ones. And then there are variants of high consequence. These we have not yet seen, and we hope that they will not arise, because clearly the variants of high consequence would be one that are not susceptible to our countermeasures. Remember that if a variant does not give an advantage to the virus, it will simply go away over time. So let's look at what's happened with the variants here in New Jersey. So we look back in December, we had very few variants. And then the alpha variant emerged and became the predominant variant that was circulating in the United States. And then in about April, we began to see the Delta variant, and very quickly, the Delta variant went from 2.3 to 5.5 to 19 to 36 to 75 to 89. And now it really, in the last week, that's not shown on this slide, it became 100% of our variants sequenced in New Jersey. So it has really taken over. And why is that a problem? It's a problem because it is more transmissible, and it's much more likely to make you sick if you're not vaccinated. The good news is the vaccines currently used are absolutely effective against the Delta variant. So what vaccines do we have? Well, for children aged 5 to 17, we have just Pfizer vaccine, and it's 2-dose vaccine, 3 weeks apart. And there's a lower dose for the younger children because they don't need as much to have a robust response and to be protected by the vaccine. For the adult primary series, you can get Pfizer, Moderna, or J&J. Pfizer, 2 doses, 3 weeks apart. Moderna, 2 doses, 4 weeks apart. J&J, single dose. Now, we know that not everyone responds to these vaccines as well. So it was noted for Pfizer and Moderna that people who are immunocompromised, transplant patients, people undergoing cancer therapy, people on corticosteroids, people on biologics, might not respond as well to the vaccines. So it was recommended in the middle of August that a 3rd dose of the messenger RNA vaccines be given to people who are immunocompromised. And it should be the same dose as they had for the first 2 series. For J&J, there wasn't enough information, so additional doses were not recommended for the immunocompromised who got J&J. Now, recently, we've realized that immunization wanes over time, and we want to have people boosted. So for booster doses, it is okay to mix and match. If you got Pfizer to begin with, you can get a Moderna booster or a J&J booster. and the same for the others. So the recommendation for booster doses for Pfizer vaccine, you get a booster dose 6 months after your second dose, and most people are eligible. So people who are at risk because of age, because they live in a congregate setting, because they work in a congregate setting, because they are exposed to other unvaccinated people on a routine basis, all of these people are eligible for that booster dose. And for Pfizer, it's the same dose as the first two. For Moderna, again, 6 months after the second dose, most people are eligible. And in this case, Moderna has developed a half dose as their booster. And then for the J&J vaccine, it is recommended that everyone who got J&J get a booster dose 2 months after the first dose. And remember, if it's more than 6 months, that's fine. If it's more than 2 months, that's fine. But it shouldn't be shorter than 2 months or shorter than 6 months. So this is a graph that just illustrates these different eligibilities and who can get which type of vaccine, and the ages and the type of vaccine and the scheduling of those. And that's what I actually reviewed in the last slide. So why do we need boosters anyway? Well, this is a study from the US that looked at the different vaccine brands and looked at your vaccine effectiveness. So after 6 months, the vaccine effectiveness of the J&J vaccine went from 86.4% all the way down to 13%. So this is leaving the vast majority of people susceptible to breakthrough infection. For Pfizer, it also dropped down to 43%. And for Moderna, it dropped the least, but still dropped to 58%. So these are not the protective numbers that we like to see. We want it to be back up in this 80%, and that's what the booster does. It increases your antibody levels and your cell-mediated immunity to give you that boost. So we're really going into the holiday season. So my plea to you is protect yourself and your families for the holidays. Do everybody a favor, get a booster dose for yourself, get a booster dose for anyone in your family who needs it. And if there's anyone unvaccinated, get them vaccinated as soon as they're eligible. Now, how do you do that? In New Jersey, we have a system where we have a call center, and we also have that call center, in addition to scheduling, answers questions that people might have about the vaccines, and they do it in a variety of different languages. We also, of course, have a website. You go to the website, hit the vaccine appointment finder, and you can find out which pharmacies, which local health departments, which places close to you have the ability for you to get the vaccine. And all you do is hit that button, put in your zip code, and it will tell you where you can get the vaccine and what types of vaccines they have. Now, this is how we're doing in New Jersey, just to give you a feel. So here are people with at least 1 dose, and the darker the area, the more of the population that's protected. And overall, our numbers, if we look at eligible people who've gotten 1 dose, our percentage is about 77%. If we look at people who have completed the course, that's down to about 66%. But that number dropped because we recently made everybody age 5 to 11 eligible. So we went from 85 and 70% to about 10% lower numbers. Within New Jersey, we've given over 13 million doses. In the country, over hundreds of millions of doses have been given, and more people are getting fully vaccinated. Now, this is an idea of, or this shows you that not all ages have gone out to get their vaccine with the same abundance as others. So for our baby boomers, those who are 65 to 79, 100% of them have gotten 1 dose, and most of them, the vast majority, have gotten a complete series, but only 40% have gotten their booster, even though all of them are eligible. Now, they've just been eligible for a month or two, but we'd like to see that number go much higher. For 80 plus, we're also doing very well, 95%, and most of them fully vaccinated, and again, boosters in 40%. But as we go down to the younger ages, this is where the vaccines fall off and where we really need to be giving our effort. So in our 16 to 17-year-olds, it's about 71%. We've been stuck for about a month at 59% for our 12 to 15-year-olds. And this number I like. We've only had the vaccine eligibility for about 10 days, but 4.5% of our 5 to 11-year-olds have already started their vaccine series. So why do we want to vaccinate adolescents? Well, we know that we can reduce the risk for hospitalization by 93%. We know that adolescents who are hospitalized with COVID-19 tend to be those who are unvaccinated, and we don't want any vaccinated adolescents hospitalized or admitted to intensive care. Another question people often ask is about natural versus vaccine immunity. Which is better? Which is longer lasting? And quite honestly, there are more unknowns than there are knowns. We know that natural immunity is solid for several months, perhaps longer. But we also know that not everybody makes a robust immune response to that infection. It may depend on a variety of things: how healthy you are when you got infected, how good your immune system is, how severe the infection was, may change your likelihood of being naturally immune. We know that vaccine immunity is pretty solid for at least that 6 months, but then it's starting to drop, as I showed you in that slide. And I probably need to change this so it's more like protection for, there is still, some protection after 6 months, but because it's waning, that's why we need the boosters. We also know that vaccine immunity against variants is quite solid, at least as I'm talking today in November 2021. We also know that both natural and vaccine immunity varies by age and other factors. And most importantly, we know that vaccines will boost your natural immunity. So it is recommended that even if you had natural disease, that you go ahead and get vaccinated to boost that natural immunity. So that's what I have to say for today. I hope you will help us spread the word that the vaccines are safe, they're effective, they're free for everyone in New Jersey and everyone in the United States. Thank you, and I'd be happy now. I'm going to stop sharing, and I'm happy to take some questions.
Thank you, Dr. Fisher, for a wonderful and very informative presentation. I do have a few questions for you. Okay. So can you have post-COVID symptoms after getting the vaccine booster?
So that has not been described yet, but I think, we've only been giving boosters for a couple months. So I think we don't know. But what I will say is you can get a breakthrough case after getting vaccinated. And certainly with a breakthrough case, it would be possible to have those long COVID symptoms. So the symptoms are not recognized after just the vaccine. They are recognized after the COVID disease. And we know that no vaccine is 100% effective. So there is a problem with the breakthrough cases. And of course, it would be sometimes really almost impossible to know whether you had an asymptomatic breakthrough case, and that's what's giving you the symptoms rather than the vaccine.
Great, thank you for that. Is it anticipated that children younger than 5 years old will soon be eligible for the vaccine?
Yes, it is. So both Pfizer and Moderna are studying the vaccine in these younger ages, and Pfizer hopes to have their information for children as young as 2 by the end of the year. So I'm hoping by 2022, we will begin to see use of the vaccine in even younger ages.
Okay. Can someone who had the vaccine had a chest pain, unable to stand, walk, severe headache, should they take the second vaccine?
So I think that's a question you need to discuss with your healthcare provider. In general, I think if you had chest pain and there's a concern that you had myocarditis after the first dose, I would not get a second dose of that vaccine. Now note that myocarditis is reported with the messenger RNA vaccines, but not with the adenovirus vector vaccine. So you could potentially get a dose of a different vaccine.
Great. How do you respond to people who say, I have antibodies, so I don't need the vaccine?
So what I would tell them is, unfortunately, those antibodies that they know they have, or because they got tested somewhere, each test measures different types of antibodies. We don't know which antibodies are protective, and we don't know what level of antibody is protected. We do know that the vaccine will boost your protection. So I would say, don't count on that antibody lasting, get it boosted so we know that you'll have more extensive type of antibody, and we know that will further protect you.
Okay. For persons who are immunocompromised, how long should they wait for the third dose? Is it also a 6-month wait?
No, it's shorter. So it's 1 month after your second dose. So if you got Pfizer, if we Pfizer first dose, 3 weeks later, Pfizer second dose, a month later, Pfizer third dose.
Okay, good. And so for the booster, are they able to mix match, or do they have to get the same vaccine that they got before?
So for the boosters, mixing and matching is absolutely fine. For the third dose, mixing and matching is not necessarily recommended. But if you got Pfizer and you can't find a Pfizer dose, you could get a Moderna for your third dose. But for the booster, you can get whichever vaccine's available. And we don't at the moment have a supply problem. So again, you can get the one that you think will be best for you.
That's good. How dangerous is it for me to be around family members for the holidays who refuse to get vaccinated if I'm masked and they do not? Are they riskier than the general public?
Well, they're certainly riskier than the general public, but because the majority of the general public is now vaccinated. However, you can minimize your risk by being vaccinated yourself, by being boosted, and by wearing the mask and keeping that social distance. Of course, the problem is that at least in America, everyone who goes anywhere for the holidays wants to eat, and you can't eat with a mask on. So yes, there is going to be a risk. We know that the new cases now are definitely among unvaccinated, but there are some breakthrough cases. So no risk, unfortunately, or no situation has a zero risk, but I would certainly encourage your relatives to get vaccinated to protect themselves and also to protect you.
Is planned travel exposure to high-risk individuals considered a qualifying condition for the booster for younger people, 20s, et cetera?
So I would say if you're 20 and you are going to be, or if you are in a congregate setting at all, so if you go to college, if you are or any kind of school setting, or even you could say if you go to regular religious services, if you are regularly exposed to people who are not vaccinated, either because of your work or your living circumstance, then absolutely you're eligible to get the vaccine.
Okay. Are the boosters the same dosage?
So for the Pfizer, the booster is the same dose. For J&J, the booster is the same dose, but for Moderna, it's a half dose.
Okay, good. Is the Pfizer or Moderna booster a single dose for those who had the J&J vaccine? A pharmacist wanted to schedule my husband for a 2-dose booster.
No, it's actually just 1 dose. And that is an important thing to remember. So if you had J&J, you just get 1 booster, as of November 2021. As of right now, it's just 1 booster. I will note that people who are immunocompromised, who get their 3 doses, they will be eligible for a booster 6 months after that 3rd dose. But probably that's going to be a while from now.
Got it. Also, are the vaccines FDA approved yet?
The Pfizer vaccine is fully licensed and FDA approved. All of the other vaccines are under an emergency use authorization. And in fact, for Pfizer use in children under 16, it's an emergency use authorization, and the booster doses are under an emergency use authorization. So the emergency use authorization is done by the Food and Drug Administration. The pharmaceutical companies have to show their information that it's safe and that the vaccine's effective. And the reason it's just an emergency use authorization is in order to get a biologic license, you have to have 6 months of safety data. So you can't get that right away. So you start with the emergency use authorization because we're in the middle of a pandemic. And then over time, you apply for the biologic license, just as Pfizer did.
Okay. The person that received the Pfizer and had a reaction with chest pain, should they consider getting Moderna?
The side effect of myocarditis and pericarditis is the same for both Pfizer and Moderna. So they could consider it, talk to their doctor, but that would be a risk that probably they should just go with the J&J.
Okay. With the long haul COVID, is the medical community treating these symptoms as a new condition or as a COVID-related issue and therefore no treatment?
So, if we knew exactly what to do, I could tell you, I could probably answer the question better. There are absolutely a lot of clinics that have now been set up and that are following people with long COVID. And they're trying to figure out exactly what helps these people and what doesn't help them. Some people getting the vaccine has actually made their symptoms much better, but that's not uniform. So we're still learning about post-COVID. I would say it's a COVID-related problem, no question about it. But the federal government and everybody else recognizes that this is a huge problem, and they're doing everything to try to get more information so we'll actually know how to treat it most efficiently, and we'll make sure that insurance companies are paying for that management.
That's good feedback. Can you please review the difference between a booster and a third dose?
So a third dose is for people whose immune system is compromised. So for whatever reason, your immune system doesn't work as well as other people's. So you're on cancer chemotherapy. You got an organ transplant and you're on chemotherapy for that. You have inflammatory bowel disease and you need to take a biologic agent. You have rheumatoid arthritis, you take biologic agents. You have very bad asthma, so you take a lot of steroids. Those people don't respond as well to just 2 doses. They need a third dose. And also, if you had an underlying immune deficiency, one of the inherited immune deficiencies or an acquired immune deficiency, you would qualify for the third dose to increase your chances that you'll respond. So that's just for immunocompromised. The booster dose is for everyone because over time, that vaccine efficacy drops. So we want to boost your immunity by giving you an extra dose. And the timing of that is 6 months after your second dose. On the other hand, the timing of the third dose is a month after your second dose, because we're really trying to get you up to those levels that you need to be protected.
Okay, good. Can you speak to Covishield AstraZeneca as a booster dosage? That is all that is available in Madagascar right now, but many experts here had Pfizer from their home countries.
So AstraZeneca is the other, that was the one that I don't know why my brain wasn't letting me think of the name. So it is the other adenovirus vector vaccine. It's used throughout the world, and it could absolutely be used as a booster for Pfizer.
So I got the 2-dose, I think you must have answered this already, but I got the 2-dose series, Moderna and Finnish series in December 2020. Do I need the third dose? What is the difference between third dose and I think so? You're already, they're coming so fast. Let's see. If a patient misses their 6-week mark to get their second dose, do they need to restart their series?
So nobody ever needs to restart a series. The only time that you have to restart a series with vaccines is if you get a stem cell transplant. So, you know, most our immune memory, it's not perfect, but you don't have to restart doses. So remember, for Pfizer, it's 3 weeks between first dose and second dose. For Moderna, it's 4 weeks between first dose and second dose. But if, let's say you got your Pfizer first dose, and for some reason you couldn't go in for that boost, the second dose at 3 weeks, you do it at 4 weeks, 5 weeks, 6 weeks, 2 months, it still counts as the second dose. You never erase that first dose. So no need to start over on any series.
Okay. I have one more question here. If women are breastfeeding, is there any immunity passed to infants?
We think so, but we're not totally sure. So the best would have been that you got vaccinated while you were pregnant, because we know for sure that pregnant women who are vaccinated, they make antibody, and the antibody crosses the placenta and protects the baby, usually for about 6 months. For breastfeeding, you're actually having the child swallow antibody that's in breast milk. And we don't know how protective that is. We know that there's lots of good things that make your immunity better in breastfed babies. And we're hoping, and there actually was just a little bit of evidence, and I'm blocking exactly where it appeared, but there was just something recently suggesting that breastfed babies whose mothers had the vaccine actually do get a little bump in their immune response from that. But exactly how protected they are, we honestly don't have that information. Because remember, when you swallow antibody, it is degraded by the stomach acid. But some of it does, you know, help you out and protects you locally.
That was really good. Thank you. So thank you, Dr. Fisher, for a very wonderful and informative presentation today. Thank you for everyone for joining the webinar. I try to get through everyone's question. We do have an upcoming webinar on December 9th. Please look out for that. And I know many of you asked this question. There is a recording, and it will be posted on the center's YouTube channel. Okay, so thank you again, everyone. And take great care. Thank you again, Dr. Fisher.
My pleasure. Thanks, everyone. Please be safe and get boosted if you need it. And get your children immunized. Thanks. Bye-bye.
Thank you. Bye-bye.